The management of hypertensive urgency requires the usage of oral drugs like captopril, labetalol, nicardipine. You can also use clonidine for that matter. For the management of hypertensive emergency, intravenous drugs like nicardipine, nitroglycerin, sodium nitroprusside, labetalol, esmolol should be used. Our primary goal in most of the hypertensive emergencies is to reduce the systolic blood pressure or the mean arterial blood pressure by less than 20 to 25% in the first hour. Okay, don't reduce more than 25% in the first hour. And the goal of 160 by 110 millimeters of mercury should be reached by next 2 to 6 hours. And eventually bring the blood pressure to normal over the next 24 to 48 hours. This is the usual advice that will be given for generally any case of hypertensive emergency, but let's look at the exceptions. When the patient is having acute aortic dissection, you have looked at the image, the intima and the media are splitting away from each other because of the flow of blood in between, and it can be resulting in a mortality of the patient. So, immediately bring the blood pressure back to 120 millimeters of mercury within the first hour and bring the heart rate to less than 60 beats per minute. This requires control of blood pressure as well as heart rate. That is why you need an intravenous beta blocker, that is an IV esmolol or IV labetalol. And you can also use vasodilator, that is nicardipine and nitroprusside in intravenous formulation. If the patient is having an acute ischemic stroke, so when the patient is having ischemic stroke, there is some cerebral vasoconstriction or the cerebral vascular occlusion. You need to maintain the cerebral perfusion pressure. Because of this reason, do not control the blood pressure rapidly. Because when you control the blood pressure rapidly, cerebral perfusion pressure also falls down. That is why there are a couple of permissible limits. When the patient is undergoing thrombolysis, the permissible blood pressure is 185 by 110 millimeters of mercury. If the patient is not undergoing thrombolysis, the permissible blood pressure is 220 by 120 millimeters of mercury. If the patient is having preeclampsia or eclampsia, again you need to immediately bring back blood pressure to less than 140 millimeters of mercury. So reduce the systolic blood pressure to less than 140 millimeters of mercury within the first hour. And the drugs that have to be used are labetalol, hydralazine, nicardipine, nifedipine, alpha-methyl dopa. All these drugs which we have already discussed in the management of a pregnant female. In case of hemorrhagic stroke, immediately reduce the blood pressure to less than 140 millimeters of mercury. Why? Because the whole bleeding that has happened inside the brain is because of the increased intraluminal pressure or the increased blood pressure in the cerebral vessels. If the blood pressure is still high, there is continuation of the hemorrhage that is happening inside the brain, and that would eventually result in the midline shift, and the patient may eventually land up in the uncal herniation, and the patient may die immediately. So, immediately reduce the blood pressure to less than 140 millimeters of mercury.
Follow me and comment notes. I will send you the link.